This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1, questions 1 to 12. You hear a neurologist talking to a patient called Danuta Parker. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Now, Mrs. Parker, I understand from your notes that you have Meniere's disease, but perhaps you could tell me in your own words when this all started, what treatment you've had, and anything else you think I should be aware of.
Sure. Well, it all started about 5 years ago, a few weeks after my daughter was born.
Mm-hmm.
I realised there was something wrong with my right ear. I couldn't hear as well as normal, and it felt like I had fluid sloshing around inside my head. Then I realised I could hear this sort of humming, which didn't stop. It was particularly loud, but I was also having moments when my head was spinning and I was completely off balance. That made me feel, very sick. The first time I told my GP about it, he thought it might have something to do with hormones because I just had a baby. But the dizziness and sickness actually got worse. So then he did a few tests and told me I had glue ear. He gave me some medication. I think it was called Benadryl.
That's a decongestant.
Yeah, and it seemed to work for a while. But then 6 months later, things began to go wrong again. I got worried about my hearing because I was having to strain to catch what people were saying. Everything seemed muffled unless they were talking loudly. And then suddenly the tinnitus came back, and with it I was getting fits of dizziness and nausea. When it came on, the only thing I could do was lie down. The best word for it is incapacitating. That's what it felt like.
How long did these attacks last?
Well, they varied. Some were quite brief, maybe half an hour, but the worst ones went on for 4 or 5 hours. It got so bad that eventually I was referred to an ENT specialist who diagnosed me with the Meniere's disease. It was explained to me that there's an abnormal buildup of fluid in the inner ear, and this affects the organs which regulate hearing and balance, but no one really knows what the underlying cause is and there's no cure. Is that right?
Pretty much, yes. And it's tricky to diagnose because many of the symptoms are also characteristic of other conditions. But it can be managed. Have you been given medication to take?
Yes, beta-histine. It's for when I have attacks. It probably helps with the dizziness, but I still feel very nauseous, and I don't like the idea of taking it long term. I was advised to eat lots of vegetables and fruit and to cut right down on the amount of salt I eat. I was also told it's best not to drink anything alcoholic. That wasn't an issue for me because I never had, but I've been drinking plenty of water and I feel that has made a difference. Also, I decided to avoid having anything with caffeine in it, and I do think that's been beneficial. I try to stay active. I go to the gym 3 times a week when I'm feeling normal. I'm also disciplined about doing the exercises that a therapist I went to see gave me. You know, the vestibular ones that help improve my balance.
That all sounds good. Do you work?
I'm a trained accountant, and I did that sort of work for several years until things got too much for me, what with having 2 young children and the Meniere's. I'm convinced that stress triggers attacks.
How often do you get them?
Well, it's quite unpredictable. I might get 5 in a month and then maybe 1 in the next 6 months. But overall, it works out at about twice a month, though things have changed again recently. I generally feel quite confident that I can deal with the Meniere's, but in the last few weeks, I've been getting something new. Without any warning, I have falls. When I'm standing or walking, I just hit the ground. I don't faint, but I can't control it. It feels like the ground is tilting and there's nothing I can do. It's frightening.
I can imagine. Okay, thank you for all that background. That's really useful. From what you've told me, I can see that we need to do some tests.
Extract 2, questions 13 to 24. You hear a paediatrician in the emergency department talking to the father of a 5-year-old girl. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Now, Mr. Bellinger, before I look at Fiona, perhaps we could just talk through what's been happening and what's brought you here today. So, Fiona's 5. Has she had any medical or other problems that I ought to be aware of?
Well, first of all, let me explain that Fiona's adopted, so we know very little about her early years. We've had her for a couple of years now, but I suppose it could be important, so I wanted you to know from the outset.
Oh, I see. Thanks.
In terms of medical conditions, Fiona gets a bit of eczema, which flares up from time to time, but it always dies down again once we apply the ointment the GP gave us. Seems to do the trick. There's nothing else, really. Not until now, anyway.
Well, let's go back to when all this started.
Well, it's been going on for 3 days, but on the first day, we noticed Fiona was picking at the area on her chin. We had a look and thought, yeah, that's a cold sore, and put some stuff on it that we already had in the cupboard. I mean, she's had them before, so we didn't think anything of it. But then I made her favourite dinner, fish and chips, and she wouldn't touch it. She had no appetite at all. I tried various ways of coaxing her, but none of them worked. I gave up in the end and just let her watch some cartoons. Then I noticed she kept getting irritable with her brothers. I mean, that's not like her at all.
Were there any physical signs, like a temperature?
No fever at all. But there were a couple of other things. She kept saying she had a sore throat, but she didn't seem to have a cough or anything. So I just gave her a teaspoon of honey and some water to drink. The other thing was that her eyes were a bit gunky, bit of conjunctivitis.
Yeah.
But again, nothing serious, so I just washed them out with some cooled boiled water, like we always do when one of the kids gets it, as they do from time to time.
Right. And then?
And then she went to bed, still not looking great, to be honest, but we hoped that a good night's sleep would help. But when we saw she was still unwell the next morning, I took her to the GP. My wife thought Fiona might be going down with chickenpox, but actually he said it looked more like impetigo. He gave us a prescription for some cream to put on the affected area, but we never really got a chance to use it because later that evening, I'd say around 6, we noticed that she was starting to come up in blisters. At first, it was just the area around her right collarbone. So we put some cream on them too, in the hope that it had helped to stop them spreading. Then, just a few hours later, we saw that more had come up on the back of her left ear. I feel awful now for not bringing her in then, but because she didn't have a fever, we thought we'd wait until morning and go back to the GP.
And that brings us to today.
That's right. She woke up at 5 a.m, crying hysterically. I picked her up, and the first thing I noticed was that she had a high temperature. I didn't actually measure it, but she felt hot to the touch. I turned on the light, and the first thing that struck me was that the area around her nose and mouth looked strange. I grabbed a tissue thinking it was a snotty nose, but then I saw that actually the skin was peeling. She was also pulling at her pyjama bottoms. She still wears pull-ups at night because she sometimes wets the bed. So I thought it must be bothering her, so I took them off. That's when I noticed how sore the skin covering almost the entire area was. Like a nappy rash, but much worse than we'd ever seen before. So we brought her straight in.
Well, you did the right thing.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a physiotherapist talking to a patient about leg strengthening exercises. Now read the question.
So, how have you been getting on with the leg strengthening exercises I gave you?
Well, I've been trying to fit them in a couple of times a day, like you said. As you know, after my fall, the problem I was worrying about was my stability. I have to say I haven't felt much change with that from doing the exercises, but I imagine I feel a bit less wobbly if I keep at them. I am noticing progress with my knees. I can bend and extend them more, and the same with my ankles, though it's more limited there. I haven't been as good as I should have been doing the toe crunches, which you said would help with my feet. But I've been better at wearing my orthotics. They've been helping with my walking.
Question 26. You hear a specialist respiratory nurse briefing a group of trainee nurses. Now read the question.
There are a lot of things to remember when carrying out asthma reviews for patients. Good monitoring is very important, both on the patient side, and we need to encourage this because efficient self-management is the key to better outcomes, and on our side too. Then there's medication, of course. Before we consider altering anything, we need to ask about the inhaler. Is the patient using it regularly? And we mustn't forget to check whether they're using it correctly and get them to show us what they do. It's so easy to assume everything's working well there when it may not be. Good technique can make a huge difference. Also, is there anything that's making their asthma worse that we can address? Then we should investigate any current lifestyle issues like exercise and weight management. These can have a serious psychological as well as physical effect on patients.
Question 27. You hear a nurse talking to a patient who's just been diagnosed with type 1 diabetes. Now read the question.
So today we'll be giving you 4 units of insulin.
Is that what I'll be getting from now on?
No, he's composed what he calls a sliding scale, which basically means if your blood sugar falls within a certain range, you'll inject a certain amount of insulin. So it'll vary.
Oh, I get it.
Good. Now, what I have here is the insulin pen. There's a little dial on this side to adjust the amount of insulin. Each number is 1 unit.
And I use this pen once only?
Well, actually, you use it each time. You see there's no needle on here yet?
Oh, okay.
Now, we always give insulin with food.
So if I skipped the main meal and took insulin, would that be a big problem?
You'd become hypoglycemic and get some scary side effects. Now, I'll show you how to put the needle on the pen.
Okay.
Question 28. You hear a hospital doctor talking to a senior nurse about an elderly patient. Now read the question.
Now, Mrs. Jackson admitted from ED last night. She'd had a fall at home. How's she doing? Any sign of dementia at all?
Well, she's appeared very subdued, even when her son's been here. She's been living alone, recently widowed. At this stage, I'd be reluctant to put anything down to dementia, and there's nothing in her notes. But she's been refusing to eat, and her BMI's low already, and her SATs weren't great this morning.
Well, I don't think we should intervene too invasively at this stage. Let's do routine bloods, check her iron levels, take a urine specimen, and check for infection.
Okay, but I'm not sure how beneficial it'll be. My feeling is, from what little I've seen of her, is that she's turned her face to the wall, given up, if you like.
Right, well, let's monitor her closely today. Hourly obs?
Okay.
Question 29. You hear a specialist dermatology nurse talking to a patient with psoriasis. Now read the question.
So, Tina, let's talk about your skincare regime.
Okay, I've been coming to this clinic for years with my psoriasis, haven't I? And the doctors have always gone, right, here's your creams, you have to put them on twice a day. And obviously they know exactly what they're talking about, how much stuff I should be using. But it was much easier when I was a kid. Now I'm older, it's tricky. Like, I probably should put the creams on morning and evening, but to be honest, I only do it later in the day.
Right.
I literally can't fit it in first thing. And anyway, if I did apply them then, my skin would look greasy all day. But I'm not worried what people say when I'm out with my face plastered with stuff. I've coped with that all my life, after all.
Of course.
Question 30. You hear a senior nurse briefing her team about patient-centered care. Now read the question.
Does anyone have any questions?
When we speak about respecting patients' wishes, what exactly do we mean?
Good question. Put simply, it's about focusing care on a patient's needs and making our system suit them, rather than the other way round. Most people needing healthcare nowadays aren't happy just to let health professionals do what they think is best. They have their own views and priorities, so we need to include them when planning care. This doesn't mean that whatever the patient says goes, but we should do our best to accommodate their wishes if we can. Do be aware, though, that patients won't necessarily tell us what they want. They may feel awkward about it or have a condition that makes communication challenging. So we have to actively encourage them to participate in their own care and negotiate with them to agree a plan that's acceptable to both them and their healthcare team.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with a senior hospital dietitian called Mark Thomas, who's talking about the condition called fibromyalgia and the dietary treatment prescribed for one of his patients. You now have 90 seconds to read questions 31 to 36.
With me is a senior hospital dietitian called Mark Thomas, and we're going to be talking about a dietary approach for a condition called fibromyalgia. Mark, could you first tell us a little about the condition?
Well, fibromyalgia can be a painful and debilitating disease, and patients often present with a variety of symptoms, such as joint pain, cramps, and chronic fatigue, which makes it hard to diagnose. There may be a genetic element to the condition, and women seem about twice as likely to be affected as men, although rates for its occurrence appear similar in different areas of the world and amongst different cultures. But for some patients, it can almost come from nowhere and afflict them quite suddenly with a rapid escalation of the symptoms.
And you've been involved in a case study of a female patient, haven't you?
That's right. Let's call her Mina. Mina was 34 at the time of the study and was someone who'd taken a lot of interest in her condition, had read all the research on it and so on. The onset of her symptoms, which included lower back pain, restless legs, and morning stiffness, occurred a few months after she'd had day surgery for an unrelated condition. She'd initially described what she was suffering as a minor complaint and erratic, although just 1 year later, the worsening of her condition was forcing her to seek regular bed rest. MRI and X-rays revealed no abnormalities, and the steroids she was subsequently given didn't relieve her symptoms. And the same was true of the painkillers she was taking.
That must have been very difficult for a woman of her age to cope with.
Well, I think certain aspects of it were more difficult than others. She worked in IT communications and was used to taking a problem-solving approach to issues. So the fact that she couldn't do that in this instance was frustrating, I imagine, although she was at least in a position to continue working from home. And she'd noticed a certain pattern in the worsening of her symptoms, which seemed to correspond with a decrease in weather temperatures during the autumn, which exacerbated her pain. Probably what she complained about most, and she's not alone in this amongst patients, was the reaction of family, friends, and colleagues to what she was going through. Because the condition isn't visible, there's therefore a certain assumption that you're somehow exaggerating the severity of your pain. It's hard to bear when you're already struggling.
Indeed. And she was put onto a therapeutic treatment? Did she supplement this with drug treatments?
No, she turned down a number of types of medication we offered, as she'd clearly done her homework on the different pharmacological therapies available. Admittedly, with one proposed muscle relaxant drug we were considering, its effectiveness hadn't been entirely proven, so we held that in reserve. But another drug we proposed was known to produce some mild adverse reactions, so that made her decide against it. Of course, there's always the possibility of overdependence to any prescribed drugs, although I wouldn't have assessed her as particularly at risk.
And how did she respond to the diet she was prescribed?
Well, compared with the patient's previous diet, the one we proposed didn't affect her total daily energy intake. It was still around 2,000 kilocalories a day. But her previous diet was mainly a Mediterranean one, which she felt was good for her overall health, rich in vegetables, fresh fruits, and so on. However, our diet was devised to help the absorption of what's known as I-tryptophan by excluding certain carbohydrates, particularly fructose, which occurs widely in fresh fruit. So it was a big change for her. She was also encouraged to keep a food diary to note any reactions to different foods and log her symptoms. But from time to time, she also moved away from the diet to see whether it was actually working. But she did see significant improvements in her condition.
Okay, and you've since had a number of other patients on a similar diet, haven't you? How have they coped with it?
Well, they've certainly seen an improvement in their symptoms, but they're under absolutely no illusion that this is the end of those symptoms, although it has at least alleviated their pain. The problem is, though, when patients have a condition which causes them chronic pain, they're desperate for a solution to it. If a treatment at first appears to work, but then their symptoms return, that's a lot to handle emotionally, and that can affect some people very badly. And of course, you can never be sure how people will interpret the diet away from the hospital, although the patients I saw were determined to stick to it rigidly.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear Dr. Hannah Story giving a presentation about ways of making test results more meaningful to patients. You now have 90 seconds to read questions 37 to 42.
Hi, I'm Dr. Hannah Story, and I specialise in medical literacy. In this podcast, I'll be focusing on the way the public understands lab test results. Now, patients have been having tests and getting test results for a long time. So why have I chosen to talk about lab test results now? What's changed? Well, it used to be these tests got ordered by the doctor and then the results came back to the doctor, who either shared them with the patient or not, depending on how much time was available and how important they seemed. But today, we have electronic portals and electronic record systems and so on. So the patient can log onto their record system and see all of their lab test results. And because test results are often released immediately, the patient may be the first person to check them. So people are seeing these results straight away without a doctor there to help interpret them. It's a massive shift. So now there's the situation where, for example, the doctor might order some liver function tests for a patient who's taking drugs like steroids that could affect their liver or some types of chemotherapy. So the doctor might get tests done to monitor this and make sure the treatment isn't doing any damage there. But then when a patient sees their results, they're going to want to know, am I okay or do I have a problem? Is this drug harming my liver? If so, should I stop taking it? And if they can't figure this out, they're going to get anxious, and that's not something we want to happen. Now, if someone's got type 2 diabetes, they'll see their hemoglobin A1C results regularly for years. These results provide a measure of blood glucose control, and over time the patient will learn something about how to interpret those numbers, either through just seeing how these change or through conversations with their doctors. They'll be aware that if their A1C is at one level, they're okay. But if it rises too far, they should maybe see their doctor. And they'll have an idea of the sorts of numbers they're dealing with. But why should anybody have to wait so long to get that information? Why can't we help provide that context from the start? And patients need to realise that figures such as percentages may mean very different things in different tests. Percentages, by definition, vary between 0 and 100. So going back to type 2 diabetes, hemoglobin A1C is reported as a percentage. But for a hemoglobin A1C, 15% is an extremely high value. Most of the action's happening between maybe 4 and 10. That's not necessarily intuitive to people. It's not even true for other tests. For example, hematocrit is also expressed as a percentage, but hematocrit can vary between 30 and 60%. So a movement of 0.5% for a hematocrit is much less significant than it would be for hemoglobin A1C. So we've started to think about how we can present the test result in a form that's easier for the patient to interpret. In most systems, a patient sees their results presented in the form of a table. That table shows the patient's result and a standard reference range. But it's not easy to see how they relate to one another. So what I'm suggesting instead is a simple line from left to right with a marker that says, your result is here, and it also shows other values so the patient gets a sense of whether their result is pretty close to normal or whether it's a long way out. We started with a slightly more complex visual in the form of a graph, and this did give more information. It showed the extent to which figures were increasing or decreasing. But we think what the patient needs is just a clear indication of where they are at one point in time. There's a lot more information which could be provided, of course, but we want to keep it simple. One little extra thing we're thinking of including, though, is called a harm anchor. This is like a reference point that the patient should look at to decide whether their result is a big deal or not. If the patient's not yet reached that point, then he or she knows it's probably not a big deal, even if they're slightly above or below the desired range. If they're past that point, it definitely is, and the patient should probably let their doctor know, and maybe he or she will get the tests repeated. So we're still working on finding new ways to help patients, but I think the results so far are very promising.
That is the end of Part C. You now have 2 minutes to check your answers.